Okay. All right. Well, it's 8 a.m. So it's time to welcome everybody back to the Department of Medicine Grand Rounds. It's hard to believe that summer is over and we're starting a new academic year. So I want to welcome everyone back into our new normal with live streaming of medical grand rounds. I also want to acknowledge that today is the anniversary, the 19th anniversary of the terrorist attack on 9/11. Kind of a sober date, particularly now that we're in the midst of another tragedy, which has lost even more lives to the pandemic, as well as ongoing racial unrest and difficult times for our country. So just wanted to acknowledge those events and thank everyone for participating. And I am delighted to have Aurora Pop-Vicas back after a COVID interruption of her prior scheduled medical grand rounds. And to introduce Aurora, we have Nasia Safdar. So Nasia, I'm handing it off to you. Thank you.
Sounds great. Thank you, Lynn. Good morning, everyone. My name is Nasia Safdar, one of the faculty members in infectious diseases. I'm delighted to introduce my colleague, Dr. Aurora Pop-Vicas today. Dr. Pop-Vicas has been here at UW since 2016. Prior to that, she completed her MD and MPH at Emory, then went to Beth Israel Deaconess for infectious diseases fellowship, as well as a research fellowship, and then was at Brown University for several years before we were fortunate enough to recruit her. She is the recipient of numerous Dean's Teaching Awards, and her area of research is healthcare-associated infections, and today she's going to tell us what it really takes to reduce hospital-acquired infection. We are very fortunate to have Aurora as a member of our faculty, and thank you, Aurora, for your time today. Handing it over to you.
Thank you so much for inviting me to talk about preventing healthcare-associated infections, which I will refer to as HAIs throughout my talk. Closures. And at the end of this talk, I hope that participants will be able to give an example of healthcare-associated infections
Aurora?
Successfully. Yes.
We're going to need to see your slides. So if you could go ahead and share those slides, that'd be great.
Okay. I need to go back because I had started. Well, how do I go back? Why won't this let me go back? Oh, here we go. Okay.
You're doing great. That's perfect. Thank you so much.
Okay. Thank you so much for inviting me to talk about preventing healthcare-associated infections, which I will refer to as HAIs throughout my talk. I have no relevant financial disclosures, and at the end of this talk, I hope that participants will be able to give an example of an HAI successfully prevented within the last decade, illustrate a regulatory or legislative strategy used to drive national HAI reduction, and describe an implementation strategy that can be used at the local hospital level to prevent HAIs. My overall goal is to describe some of the necessary ingredients for successful HAI prevention. I will do so first by starting with a few historical examples, followed by some contemporary experiences with HAI prevention at both the national as well as the local level, and end with a summary of lessons learned. The troublesome statistics that you see on this slide show that HAIs persist in our healthcare much more frequently than we would like. Behind these numbers, of course, are actual patients, some of whom you may have encountered in your own clinical practices at some point. From my experience, I'm reminded of a 46-year-old man who was persuaded by his brother to undergo a knee replacement at a rural hospital in Wisconsin. The patient is a farmer, so he timed his surgery for the beginning of the winter, expecting to be recovered enough to help his brother with the spring planting season. Unfortunately, a prosthetic joint infection became apparent within 2 weeks of his operation, and after several months of IV antibiotics, 2 additional knee surgeries, and several other unforeseen complications, his mobility is still impaired and his livelihood on the farm severely affected. The healthcare epidemiology and infection control is the discipline that aims to prevent HAIs, such as the one I just described, and its importance as a discipline has steadily risen over time. The origins of epidemiology trace back to London in the 1800s, when, if you remember, the most common disease treatments consisted of bloodletting, laxatives, opium, peppermint, and brandy, none of which very effective for epidemics like cholera, for example, which were rampant at the time. In this context enters John Snow, a physician way ahead of his time in suspecting cholera to actually be a contagious disease caused by germs ingested from polluted water. By contrast, most of his colleagues believed cholera to be the result of miasmas or bad poisonous gases arising from places of organic decay. John Snow found that family households supplied by sewage-contaminated water had a much higher death rate than others. He then investigated almost each affected house in London and narrowed down the outbreak location within walking distance of the Broad Street pump, which he suspected must be the contaminated source. He pleaded with the local authorities for years to remove the pump handle, and once that was finally done, the outbreak effectively ended. Although John Snow today is generally recognized as a founder of epidemiology, his infectious disease views were not accepted by the scientific community of his time. Nevertheless, he achieved fame due to his work with anesthetics. In fact, he administered chloroform to Queen Victoria at the birth of her 8th child, Prince Leopold, and thus remained well respected by his peers. The same cannot be said, unfortunately, of Dr. Semmelweis, a Hungarian physician practicing obstetrics in Vienna. In 1847, he observed much higher maternal mortality rates among women treated by physicians and medical students compared to those cared for by midwives. He also noticed that a pathologist who sustained a scalpel injury while performing an autopsy died of sepsis similar to postpartum sepsis that affected so many women patients. Semmelweis wrote then that both a scalpel and a physician-contaminated hand would transmit deadly organisms to mothers during labor. He then introduced chlorinated lime hand washing to the obstetric hospital staff and successfully reduced maternal mortality from 18% to 2%. Although he was the first physician to actually describe an HAI in detail and introduce an effective intervention, his views were dismissed by the medical establishment. He was in fact quite hated by his colleagues, who were outraged at the suggestion that they were responsible for their patients' deaths. And to make matters worse, he used to walk the hospital corridors, hurling outrageously rude insults to some of the most powerful doctors if they dared question his views. So he eventually lost his academic appointment and was committed to an insane asylum where he died at the age of 47. Of course, once Louis Pasteur discovered bacteria through the alcohol fermentation process experiments and established the germ theory of disease more firmly within the medical scientific community, the views put forth by the early epidemiologists became more accepted. Another major contribution to the field of epidemiology, in particular healthcare-associated epidemiology, came from Joseph Lister, a surgeon in Edinburgh. He operated on a 7-year-old boy who had been run over by a horse carriage and suffered a compound leg fracture. Lister applied carbolic acid, a disinfectant solution, during the operation and to the surgical wounds for a full 6 weeks, after which he was overjoyed to find that the boy's broken bones had joined back together without nary a trace of infection, which previously had been deemed impossible. He described his experiences in the Antiseptic Principles of the Practice of Surgery, which were published in several issues of The Lancet in 1867. These articles are still considered among the most important scientific writings that forever changed the practice of surgery, laying the foundation of what later became the aseptic OR standard. Surgeons who incorporated Lister's principles of antisepsis into their practice throughout Europe in the early 20th century reduced their post-op infection rate by 80%. We have come a long way in the practice of hospital epidemiology since the 19th century. Healthcare is now a very complex environment where HAI risk is increased as patients are transferred back and forth between hospitals, nursing homes, dialysis centers, ambulatory clinics, and the nosocomial pathogens that might be carrying are more likely to spread between these settings. We also have more patients susceptible to infection by virtue of immune compromise as we care for those at extremes of age and expand our transplant services. And we continue to use invasive medical devices that alter natural barriers to infection, all of which increase HAI risk. However, although challenges remain, we have also seen remarkable successes in the field. For example, with central line-associated bloodstream infection, or Klebsi, which in the last 15 years have been dramatically reduced in all hospital settings nationwide. You probably remember the seminal paper by Peter Pronovost et al. In the New England Journal, which described the work on ICU Klebsi reduction in the state of Michigan. The intervention used was part of a statewide safety initiative known shortly as the Keystone Project and funded predominantly by the Agency for Healthcare Research and Quality. The study intervention consisted of the 5-element bundle recommended by the CDC as having the greatest effect on Klebsi prevention. We are all familiar with this quote checklist, which includes, of course, hand washing, full barrier precautions during central line insertion, cleaning the skin with chlorhexidine, avoiding the femoral site if possible, and removing unnecessary catheters. This 5-element bundle was responsible for a reduction to 0 and sustained for 18 months throughout the ICUs in Michigan. This intervention was then expanded nationally, as described by the group in this paper, which showed that the majority of the ICUs participating in the study achieved a median of 0 Klebsi incidents throughout the study, which was 18 months in follow-up. So the intervention was sustained. Of course, the real meaning of a 0 Klebsi infection rate translates into hundreds of lives saved and hundreds of millions dollars in excess costs averted. So how was this accomplished? Let's take a closer look. It started with a change in hospital culture. In particular, changing clinicians' mental models about how they think about HAI prevention or what causes HAIs. According to Peter Senge, a world-renowned social systems engineering at MIT, mental models are the ways we unconsciously view the world, which cause us to reflexively act during our day-to-day lives. If we extrapolate to healthcare epidemiology, the way clinicians think about how HAIs occur influence their adherence to infection control norms. So the first challenge was to change clinicians' mental models from the belief that HAIs are inevitable due to the complexity of our healthcare, the susceptibility of our patients, and the invasive procedures we do. Move away from this to the assumption that all HAIs are preventable until proven otherwise. These concepts are described by Suresh and Edwards in their paper on Klebsi prevention in neonatal ICU. So, in this way, HAI prevention became an integral part of the patient safety culture. This paper by Mary Dixon Woods et al. Provides further insight into the national success with Klebsi prevention, which in essence was an implementation success using the 4E strategies, engaging executive leaders, ICU directors, frontline clinicians, other healthcare workers, and when appropriate, patients and their caregivers, educating them about the processes of Klebsi prevention, which are then proficiently executed and consistently evaluated. As I mentioned before, the 5-element Klebsi prevention bundle was integrated within the larger context of Comprehensive Unit-Based Safety Program, or CUSP, which now is the patient care norm for most clinical departments. In general, it engages executives, it educates staff on the science of safety, it identifies and learns from defects in care, and it implements improvement tools and teamwork tools. All participating ICUs in the study received extensive training, support, and direct assistance with implementing the Klebsi prevention bundle. They were also provided with regular feedback on their Klebsi rates and adherence processes on a regular basis, but most importantly, nurses were also empowered to ensure strict physician compliance with this checklist. Around the same time, the regulatory health climate in the country underwent significant reform. Congress passed bills that allowed mandatory public reporting of certain health quality metrics, which include hospital HAI rates. HAI performance became tied with Medicare and Medicaid payment, and it was incorporated within the value-based purchasing program. This allows CMS and other potential payers to provide hospitals with financial incentives or penalties based on their HAI rates and performance. So, we now practice in a complex and tightly regulated healthcare environment in which patient safety and by extension HAI prevention is no longer the sole domain of infection control, but it is in fact everyone's responsibility. We have objective tools now to measure the safety climate of a given unit or healthcare institution. For example, via the Safety Attitudes Questionnaire, which is one of the most widely used scales for this purpose. And it measures healthcare workers' perceptions in several domains considered related to patient safety, such as clinicians' ability to work collaboratively in teams, their job satisfaction, their perception of management, and supervisors their safety climate in their unit, their working conditions, and their ability to recognize and manage stress. This scale was employed by the Keystone Project leaders to measure the change in safety climate throughout Michigan's ICU before and after the implementation of their safety initiative and Klebsi prevention intervention. This study found significant improvement in 5 out of the 7 safety climate domains queried, in particular, handling medical errors, providing and receiving feedback, reporting safety concerns, learning from errors, and knowing where to address safety-related questions. These all improved significantly within the 2-year study frame. The impact of the larger national healthcare reform process with the policy of non-payment for preventable infections in U.S. hospitals has also been evaluated. For example, in this New England Journal medical study funded by the AHRQ. The study actually showed that national Klebsi incidence rate before and after the CMS policy implementation was unchanged. And the authors concluded that not paying hospitals for HAIs did not have any measurable effect on the incidence of either catheter-related bloodstream infections or urinary tract infections, which in fact were decreasing long before the 2008 CMS policy implementation. Why might this be? A possible explanation for this finding is provided by Herzer and Pronovost in this paper, which contrasts intrinsic motivators for behavior change, things such as inner drive for success, desire to excel, versus extrinsic motivators such as financial rewards and punishments. We can probably all agree that clinicians are motivated primarily intrinsically by their desire to excel in their practice and to do best for their patients, both of which are inherent to the professionalism of medicine. So HAI prevention models that appeal to clinicians' intrinsic motivators, engaging them to implement evidence-based practices through peer learning or peer pressure, for example, are more likely to succeed. Once zero Klebsi rates were demonstrated possible, the next question was, how can we translate this approach to other HAIs? And while there has been some significant success with some HAIs, such as catheter-associated UTIs or C. diff infections, surgical site infections have persisted relatively unchanged. For example, the most recent CDC National HAI report notes no significant changes in abdominal hysterectomies or colon SSI rates, these being the 2 surgical procedures under mandatory public health reporting currently. And why might this be? If we start by looking at the literature, we find that for colorectal surgery, for example, we can expect a 44% HAI reduction in centers that employ very complex SSI prevention bundles that contain at least 11 different infection control elements. Contrast this bundle with the 5-element Klebsi prevention bundle or checklist. And also, although some elements are correlated with highest SSI reduction, we really need the composite effect of the entire bundle to obtain a significant HAI reduction. We have such a complex SSI prevention bundle here at UW Health. It was actually rolled out in 2016. And as you can see, it includes multiple infection control elements throughout the entire phase of the surgical care. It includes preoperative, intraoperative, and postoperative interventions. Some of these tasks are under clinician control, primarily in the OR. Some require patient or caregiver assistance, especially for some of the preoperative bioburden reduction elements or postoperative wound care. So, how do we successfully implement such a complex bundle throughout the institution? In particular, how do we get people to actually adhere with all these requirements? If we look at behavioral theory frameworks from psychology, for example, we can see that behavior is primarily determined by capability, motivation, or opportunity to change. Each of these domains have associated constructs that further define their role. For example, motivation is influenced by social and professional roles, things like beliefs about capabilities and consequences, optimisms, or emotions. To assess our clinicians' perceptions about the adherence to the newly introduced SSI prevention bundle, we interviewed 10 surgeons and conducted focus group with 27 other surgical clinicians throughout UW Health from various surgical departments within the first 2 years after SSI bundle implementation, and used behavioral change theories for analysis. And our results, under the capability domain, we found that frontline clinicians were in need of more training to correctly apply skin prep, for example, or to maintain sterile OR aseptic conditions throughout the surgery. That the SSI feedback that we were providing at the time, which consisted of aggregated SSI rates emailed to each department chair, was barely acknowledged and generally perceived as unhelpful. That introducing all these infection control requirements within a short period of time was overwhelming, and that surgeons were not likely to comply with new recommendations unless they were convinced of very strong supporting evidence for each. We also found that surgeons and surgical clinicians in general are very skeptical of policies imposed from outsiders and would rather have autonomy and direct involvement in policy making. There was also a fair amount of negative emotion in response to the way feedback about SSI prevention was provided at that time. And they felt more blamed for having SSI without really being provided with workable solutions. In terms of opportunity, the need for system-based changes also became apparent. For example, focusing less on rapid OR turnover and more on adequate cleaning between cases, or the need to minimize OR traffic and crowding, or the strong need to have surgical leaders drive the changes in the culture and workflows needed to successfully implement the SSI prevention bundle. So these concerns were addressed by what is now our UW Health signature intervention named Strike Teams, implemented on January 1st, 2019. These are multidisciplinary teams empowered and strongly supported by high-level institution administrative leaders, in our case, the VP of Quality and Patient Safety. They are led by surgeon champions from each department, with guidance from the director of the OR services, and consulting contribution from multiple related disciplines, including anesthesia, infection control, pharmacy, and representatives from frontline clinician leaders. These teams meet monthly to review in detail each SSI case. They also look at bundle adherence to each element, come up with practice changes needed to go forward, analyze trends in either adherence or infection rates, which are then disseminated by the surgeons to their teams on an ongoing basis. So the results of these interventions can be seen on this graph. As you can notice, the bundle introduction in 2016 really didn't have any effect on HAI reduction. On the contrary, However, once strike teams were introduced last year, we saw an SSI rate of 0 for the entire year of 2019 in abdominal hysterectomy. And I want to emphasize an entire year of 0 SSI in abdominal hysterectomy at UW Health, which performs some of the most complex surgeries in this field, primarily gynecology oncology, with some of the sickest and most vulnerable patients, including those with ovarian cancer. We also had dramatic and sustained reductions in colon SSI after we introduced strike teams, as noted in this graph. In summary, successful HAI prevention is now a science that integrates concepts from many other disciplines. I gave the example of healthcare epidemiology, behavioral psychology, implementation science, and social systems engineering, for example, but there certainly could be others. HAI prevention works on changing clinicians' mental models from inevitable to preventable. It requires strong support from institutional leadership at the highest level. It encourages multidisciplinary collaborative teamwork within a culture of patient safety and continued quality improvement. Learning from history and our own experiences, we are becoming more diplomatic in our interactions with colleagues and the C-suite when presenting, quote, uncomfortable data, while continuing to recognize that safe healthcare is everyone's responsibility. In closing, I want to mention that when I first started working in infection control, I did not believe a 0 rate of HAI was possible, certainly not for surgical site infections. Within the last few years, being engaged in some of these processes, I became an optimist. I realize that I'm saying this while we're experiencing a pandemic with unusual features, such as skepticism or lack of support from the general public, occasionally from the government, for even basic public health recommendations. That said, I would like to end with a quote from Louis Pasteur, which I think is still applicable today. Doctors and scientists of the future, do not let yourselves be tainted by apparent skepticism, nor discouraged by the sadness of certain hours that creep over nations. Do not become angry at your opponents, for no scientific theory has ever been accepted without opposition. Say to yourselves first, what have I done for my instruction? And as you gradually advance, what am I accomplishing? Until the time comes when you may have the immense happiness of thinking that you have contributed in some way to the welfare and progress of humankind. Thank you very much for listening. I am available for questions if there are any.
Great. Thank you so much for a wonderful walkthrough time of the history of infections and epidemiology. I particularly love the historical context of the field, and I also think it really highlights the idea of right idea, wrong time, and needing institutional readiness to implement changes that are needed. So for questions, please put them in the Q&A section. While I will ask, so you sort of alluded to this idea that it is possible to get to a 0 rate. And in the ICU, certainly as a pulmonologist, one of the areas that we always have that debate about is with pneumonia or ventilator-associated events. Do you think that is possible to get to 0 in every hospital-acquired infection? What is our bottom line?
So I think that 0, of course, is an aspirational goal. And if we operate with that mental expectation that we strive for 0, we are more likely to be more adherent to all the recommendations and pay more attention to prevention. Whether zero will truly happen on all HAIs remains to be seen, but certainly reductions can happen. There is significant work in the field of VAPs or HAPs. Sometimes it's difficult because the definitions are not really that clear, and there's room for interpretation and clinical subjectivity. What is really a VAP? So the majority of the research has been conducted on infections that have more standardized definition and perhaps are more objective or clearly defined so far, but certainly this is work for the future.
Great. There's a question from Jackson. Femoral site is often used in IR procedures. Does use of femoral site translate into higher infection rates in patients who undergo these procedures? And do you have an idea about hospital-acquired infection rates in IR procedures in general, and what's being done in the IR suite to prevent these?
So from what I know, the IR-related procedures have a very low infection rate. All the insertions are done under strict, rigorous infection control guidance. And while the femoral rate for central line insertion is more likely to become infected, especially if the catheter is maintained for a long time on the floor, it is not necessarily related to the IR setting, but more to maintaining the catheter on medical wards or in the ICU for a prolonged time and other risk factors.
And then what is coming up in the future in terms of technology to try to decrease some of these infection rates? You know, whether it's antibiotic coated lines, I remember copper beds and other more technological driven interventions.
Sure. So these prevention bundles are forever increasing with new elements added, some of which are related to medical technology. I am particularly thinking for the surgical site infections, we just recently added antimicrobial sutures, which have some evidence that they decrease wound infections postoperatively. Another medical technology-related intervention has to do with the way we clean the hospital environment in between patients. This has been a fairly difficult and challenging process to adequately disinfect and clean the rooms in all the important areas, or virtually in all the high-touch areas in between patients. Just with environmental services traditional cleaning practices alone. So now we have the UV light type devices that are an adjunctive to the traditional cleaning, and the combination works much better in terms of effectively disinfecting the environment.
Great. Okay. Shout out from Amy Kine. Also wants to know, given past experience with hospital-acquired infection government policy and our current government situation, do you have an approach to or policy recommendations to how we should be thinking about improving hospital-acquired infection rates across the country? How can we use our experience and impact changes around the world?
Mm-hmm. Sure. So I don't necessarily mean to imply that there was no effect whatsoever on HAI reduction secondary to government policies. That study that I presented was an earlier study, but subsequently a lot has been written on other potential effects of these policies. For example, resource shifting or allocating increased resource to infection control practices within hospitals, and in general, making physicians more aware or bringing the issue to the forefront in everybody's attention must have had an impact in the way we all practice and has led to more sustained HAI prevention. So I think that there is definitely a role for governmental policy, institutional policies, institutional resources and support towards engaging everyone in HAI prevention. I also think that the interventions that seem to be working in one setting, for example, the Michigan State Collaborative that was successfully expanded nationally, or other interventions that we may find locally, for example, our strike teams, we can try to see if these can be translated or adopted to other fields, other departments, or if they would work in other hospitals, and try to make policy around these type of interventions if they do prove successful in multi-site studies, for example.
What seems to me is the experience here. My take-home message is the importance of engaging the relevant stakeholders in the process. And I wonder if implementing surgical strike teams in other places from externally would be as effective compared to getting buy-in prior to establishing the intervention.
Right.
Because for me,
definitely. Yes, definitely.
Yeah. What kind of interventions do you think are the hardest to implement or have the most resistance? Is it easier to change a tool or to change a habit? I think I know the answer.
Right. So I think that we all have tried to use medical technology and devices to either supplement or substitute problems with or difficulties with behavior change and changing habits. But I think that we've also made progress in that direction as well. So the combination seems to work best. What are the most difficult? It depends on each, the culture for each department. I think in general for physicians, it is difficult to convince them to implement something they don't believe in or they don't think has really strong evidence. For clinicians and staff, I think it's difficult to implement infection control or recommendations that are not supported or are not adequately resourced. So if the clinicians feel that they just are physically not able to comply because the resources are not there for them to do their job, then it's impossible.
What are your thoughts about public reporting of our rates of hospital-acquired infection? Good thing, bad thing?
So I think that I am somewhere in the middle towards good, perhaps. Initially, my skepticism was related to whether the comparison between hospitals is adequately risk adjusted. Are we really being unfairly penalized, let's say, because we provide such higher risk care compared to other hospitals, and are we really compared to our peers? But this skepticism, I don't necessarily hold anymore after I saw that we could make real progress even here in tertiary coronary type center, where we do have very high risk patients and high risk procedures. So I think that while perhaps the public reporting and risk adjustment and hospital comparisons are not perfect, perfect maybe is the enemy of the good. So I think that it does make some difference, and while perhaps it's not the primary modality that drives reduction, it has a role.
Okay, great. Okay, thanks. I think that's all the questions for now. I want to thank you for a wonderful overview and walkthrough time.
Thank you.
I want to thank all of the participants for coming, and I look forward to seeing all of you virtually, at least on a weekly basis. Just a reminder to fill out your evaluation forms. We are going to be tweaking those evaluation forms in the future, just FYI, but in the meantime, please fill them out and give us feedback. And thank everyone, Nasia, Clint, and Aurora. All right, take care, everyone.
Thank you very much.